Hello, my name is Melendhran Pillay. I'm from the Department of Virology at Inkosi Luthuli Central Hospital. I'm a senior medical scientist and I supervise the molecular HIV resistance testing. The title of my presentation is The Early Emergence of Dolutegravir Resistance in Integrase Strand Transfer Inhibitor-naïve patients in KwaZulu-Natal. The current antiretroviral therapy program is significantly hampered by the spread of NNRTI-resistant viruses. There has been a large-scale rollout of a potent INSTI known as DTG or dolutegravir. DTG is now part of a first-line fixed-dose combination known as TLD. TLD consists of tenofovir, lamivudine, and DTG for adults, adolescents, and children over the age of 10 years and weighing greater than or equal to 35 kilograms. For patients failing a first-line regimen of TDF, efavirenz, and FTC, the second-line regimen is AZT plus 3TC and DTG. So despite the effectiveness of DTG, there's reports of the emergence of DTG-associated DRMs and persistence of HIV drug resistance. There's limited information on the selection of INSTI DRMs, especially amongst HIV-1 subtype C infected individuals in a real-world setting with a high population prevalence of HIV. So the aim of the study was to assess for HIV drug resistance in INSTI-naive patients failing DTG-based ART in KZN, and the objective was to perform Sanger sequencing on samples from patients with virologic failure on DTG. And as can be seen by this illustration, we've sequenced the Pro, RT, and INT gene. There were 227 HIV drug resistance genotyping requests for patients with virologic failure to DTG between period January 2021 to December 2024. 10 specimens were excluded as the request did not meet criteria for testing. 217 specimens were processed for HIV drug resistance genotyping. 6 had negative amplification as the viral loads were less than 1,000 copies per ml. Positive amplification with integrase genotyping results were observed in 211 specimens. DTG resistance was observed in 36% of the specimens. So 68% of the patients were female. The median age in years was 33. The median log 10 viral load was 4.8. Most of the patients were on a previous first-line regimen consisting of efavirenz, either FTC or 3TC, and tenofovir. The bulk of the patients, or most of the patients, were on a previous second-line regimen consisting of either 3TC, FTC, AZT, and lopinavir. 139 patients, which made up the majority, were currently on TLD. The duration of DTG was 12 months. So looking at the levels of INSTI resistance, 64% of the patients were susceptible to DTG, REL, and albutegravir respectively. However, 9% of the patients had high-level resistance to DTG, 10% had intermediate, and 17% had potentially low-level resistance to DTG respectively. And if we look at the distribution of INSTI mutations, we can see that the most common mutations were in codons 263, 138, G118R, 155, etc. Accessory mutations were observed, such as the T97A and the E157Q. However, these mutations had no effect on DTG resistance. The 75 patients specimens analyzed, 77% showed at least one resistance mutation within the RT gene, conferring resistance to the NRTIs and NNRTIs. So we see here that 56 patients had mutations conferring resistance to the two drug classes, whereas 2 patients had mutations conferring resistance to the 3 drug classes, which is the NRTI, NNRTI, and PI. We observed relatively few patients with high-level resistance to DTG, relatively low levels of darunavir, etravirine, and rilpivirine resistance observed in those with DTG resistance. Of concern is the emergence of DTG resistance in a short period of time. Suboptimal adherence and HIV disease biological factors may contribute to emerging drug resistance. Patients with a low CD4 count and high viral loads may be at a greater risk of virologic failure and the emergence of resistance. This data suggests that caution should be taken when transitioning patients to a DTG-based ART, as a single drug switch may result in DTG monotherapy due to an inactive NRTI backbone. Continued surveillance of drug resistance levels in our setting is needed to guide management of patients on ART.